today. My name is Nina, and I am the founder and CEO of Pre-Health Shadowing. Pre-Health Shadowing is a student-based, student-led nonprofit organization focused on creating opportunities for pre-health students globally during and thereafter the COVID-19 pandemic. Thank you all for joining me today. We do have closed captioning for all of our virtual shadowing sessions to accommodate students of all abilities and needs. If you have any ideas about how we can be more accessible, feel free to email us at info@prehealthshadowing.com. Additionally, if you want to stay up to date with all of our virtual shadowing sessions, I recommend you sign up for our email list. You can do this on our website. And once you do that, you want to just go ahead and make sure that our emails are making it to your inbox so that you can see them when you want to see them. And so I recommend saving Pre-Health Shadowing as a contact in your email list. Pre-Health Shadowing is a global organization that serves students all over the world in any interest, field, specialty, or background. Go ahead and drop in the chat where you guys are calling from today. Wonderful. If you want to stay in the loop with all of our virtual shadowing sessions, you can, like I said, sign up for our email list and follow us on social media. We are on Instagram and TikTok at Pre-Health Shadowing. You can also follow us on Facebook and Twitter. Being a part of Pre-Health Shadowing, it has its perks. We have partnered with Kaplan. If you respond to our survey link in the chat, you can get 10% off any Kaplan course and get free study guides for the MCAT, GRE, PCAT, NCLEX, and more. So if you guys are preparing for any of those for your next stages in your healthcare path, I really recommend you sign up for this. Additionally, mental health is of utmost importance, especially during this time when we are in isolation. So we have partnered with Neolith to offer our students free mental health platform in collaboration, also giving students internships in psychology, and they have other certificate opportunities. So if you guys are interested in that, you guys can go ahead and check them out, Neolith. We have also partnered with the women-led organization Mask for Mask, which for every 4 mask purchases, 4 masks will be donated to others in need. You can actually help 2 good causes at the same time, because every time you purchase Mask for Mask and use the code PHS15, you will actually donate 10% of those proceeds to Pre-Health Shadowing to keep virtual shadowing free and accessible for everyone. If you're interested in being a part of helping our organization grow, you can help us out and be a part of our student-based, student-led organization. You can be a student volunteer, which we have synchronous and asynchronous opportunities where you can create your own schedule and collaborate with students globally. Additionally, you can apply to become in a leadership role within Pre-Health Shadowing and work to manage the National Pre-Health Shadowing organization as we continue to expand. If you are a high school student, we also have opportunities for you. If you're looking to establish Pre-Health Shadowing as a club on various high school campuses, this is the opportunity for you. You get to collaborate with other high schoolers and work with them to really expand the program and allow students to learn more about the various fields within healthcare. You can apply to join our high school training program online and fill out the application form. If you are looking to get published, we do have opportunities for you as well. You can get featured in Pre-Health Shadowing by submitting any essays, reflections, research papers, reviews, success stories, and member of our student team, Muntaha Islam, who is our editor-in-chief, will work alongside you to ensure that this is the best paper you can have. And this is a wonderful thing to have featured on our website, as you can use this on your resume, application, CV, and even feature it on your LinkedIn profile. You can submit articles, blogs, and reviews and success stories on our website, prehealthshadowing.com/blog submissions. Part of our mission at Pre-Health Shadowing is to promote diversity, and in order to do so, we will be bringing in professionals and members of all different groups to talk and chat about healthcare and really learn more. If you know somebody inspiring and you want to nominate them to join our talk, please nominate them today. You can check the link in the chat and fill out the form. Pre-health shadowing is a student-based, student-led, nonprofit organization which functions solely off of the donation and time of our volunteers. If you could please help us by sending us a little bit of money. This could be a few dollars. This could be sending this to someone who you feel could donate if you are not financially able to at this time. That would really help our organization. We grew a lot faster than we thought we would, and we are here to offer our services and have vowed to keep pre-health shadowing free for students. And so please help us keep our promise by providing the opportunity for us to support our platforms. Thank you. Throughout the duration of today's virtual shadowing session, you can go ahead and drop your questions and comments into the chat. Members of our student team will be able to ask those questions during the Q&A portion during the second half of today's session. I encourage you all to take good notes, as we do have a post-shadowing assessment, which will allow you to gain a certificate that verifies your virtual shadowing hours in our program today. This will be made available after today's virtual shadowing session. We want to make this as close to an in-person shadowing experience as possible. So if you are able to, please do turn on your camera. This isn't mandatory, as we recognize not everyone is able to, but if you can, please do, as it's not always fun to talk to a bunch of little squares. Thank you all. If you guys are interested in viewing our Women's Summit, you can check it out on the website. There is going to be more information regarding that. Without further ado, I would like to welcome to you our professional for today. Thank you for joining us, Dr. Minck.
Thank you. Thank you so much. I'm so happy to be here.
Wonderful. So we're going to go ahead and start sharing slides. But before we get started, we're just going to release a polling question. So Matt, if you can go ahead and release the pre-polling question for our students. This is going to ask you where you are Zooming from and where you are in your educational career path. And Susan, you can go ahead and share whenever you're ready.
And also, Dr. Minck, whenever you're ready to move on to the next slide, just please let me know by saying next slide, and I will move right next to the next one. Thank you.
Okay, sounds good. Whenever you're ready, you can throw up the first one.
Yep, definitely.
Just let me know when you're ready to go.
Awesome. So it looks like we have a lot of high schoolers and undergraduates joining us today. Additionally, we have a lot of West Coasters. That is where I'm at too. Let's represent. So awesome. That gives us a little bit more information about who we have joining us today. All right, the floor is yours, Dr. Minck.
Thank you. Okay, yep, that's the first one. Hello, everybody. I'm so happy to be here with you today. My name is Sandra Minck. I'm a registered diagnostic medical sonographer of 29 years. I spent 25 years in clinical healthcare and clinical ultrasound, and with the focus on the past 4 years in health communication writing. I'm the author and creator of ultrasoundunwrapped.com, mostly because I want to share ultrasound information with expectant parents and students, because there really isn't a whole lot of information out there on ultrasound that I felt was accurate. Also at Ultrasound Unwrapped on Instagram. And then I'm also the author of my very first book that was just released on May 4th. And you see that on the screen, Ultrasound Unwrapped, a week-by-week pregnancy image guide. Basically, because pregnancy guides don't include images for parents, they don't really know what to expect to see on the monitor when they present for their examinations. So I included about 160 images, kind of teaching them what they should expect to see in the first trimester during their confirmation and first trimester examinations between weeks 4 and 13. And then also I cover growth with images in the first trimester, teach them about what ultrasound is, the role it plays in their pregnancy, and then also kind of the fun part in part 3 is picking apart gender identification. That seems to be what most parents are, really excited about after all the hoopla of the positive pregnancy test and all that. So yeah, it's just kind of my way to sort of give back and educate expectant parents, not being a clinician. So thank you to Pre-Health Shadowing again for having me here today. This is a fantastic opportunity, like I said, for myself, and then for students who are either studying ultrasound right now or looking into going into ultrasound. I certainly never had opportunities like this way back when. So this is great for all of them to gain a little insight in advance. I'm here strictly as a volunteer. I love teaching about ultrasound, and I'm honored to be here. So I'm looking forward to giving you as much information as I can possibly squeeze in tonight. We'll have a Q&A session at the end. On every slide, you'll see my email address. If we don't answer, if I don't get to your question tonight, feel free to shoot me an email. I will answer every one of them personally and try to get all of your questions answered if you have any others. So let's see. Let's get into what ultrasound is. What it is and what do we do. Now, if any of you are already in allied health, and maybe you're transitioning into ultrasound, you may already be familiar with what we do and how we do it, the role of ultrasound, what our job is as a sonographer. If you're new to ultrasound, if you're right out of high school, if you're contemplating ultrasound, but you really don't know a whole lot about it, then this is for you. So to define ultrasound, we use it's the utilization of sound waves, not radiation, but sound waves to penetrate the tissues of the body, project back through to the monitor and image of our organs. It is the most operator-dependent modality in all of radiology. All this means is that our eyes are super important. The machine does nothing without our making it work. So a little more pressure there, and a little bit more of a learning curve. So, it's our responsibility to create the images, to make the necessary documentation, to discover pathology if it exists, to report it accurately and properly. Basically, we are painting a picture for the physician, for the ordering physician or the reading physician about what is going on with this patient, so that the patient's ordering physician can better manage his or her care. Ultrasound is it's a process. It's a long learning process. You have to learn normal in order to recognize what abnormal is. And this takes time. It takes time and experience. And it doesn't come overnight. It doesn't matter who you are, how brilliant you are. No one can learn ultrasound overnight. And like I said, it is a process. So with time and experience, you develop your skill. And as you develop your skill over time, you also increase your confidence in your skill and ability for what you're doing. And that makes a very intimidating scan maybe early on in your career a welcome challenge a little bit later on. And you can feel that as you're progressing in your studies and in the workplace. With each examination, you can feel that you're getting stronger with what you're doing. With every correct diagnosis, with every pat on the back from your radiologist or the physician you're presenting to, you build up a little bit more confidence in what you're doing. So let's see, ultrasound applications. Most people are familiar with ultrasound as far as OB-GYN goes. Most people are familiar with, you know, the fetal sonogram. But ultrasound has many applications in the body. There is abdominal ultrasound, small parts like the thyroid, testicle, breast ultrasound, obviously OB-GYN, women's health. There's perinatal ultrasound, which is maternal fetal medicine or high-risk OB ultrasound. If a patient presents to her obstetrician, there's a problem with the fetus, or another condition that needs to be managed, like, you know, hypertension or gestational diabetes, the obstetrician may refer that patient out to the perinatologist or maternal fetal medicine. Also, fetal echo is an important part of maternal fetal medicine. There's also adult echocardiography, echo being the study of the heart. MSK is a new one for me, shall I say. MSK is not new, but it seemed to gain some popularity and some usefulness in the field after my training, well after my training, probably several years after my training. So I don't really know, never really had any exposure to that, but it is the application of ultrasound to muscles and ligaments and joints and nerves. So it's used a lot in sports medicine. And there's neonatal heads, neonatology and pediatric studies. And then also carotid Doppler studies, peripheral vascular studies, you know, carotids being the arteries in the neck leading to the brain, peripheral vascular studies, arterial and venous studies in the arms and legs, venous studies looking for clots, arterial studies looking for stenoses within the arteries and blockages. Let's see, another aspect of ultrasound and what we do is what we're exposed to on a daily basis. So I have gotten a lot over the years. Do we have to work with blood and body fluids? Yes, 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 yes. Yes, we do. If you have an aversion to blood and body fluids, ultrasound is not for you. And certainly there is more exposure to that in certain applications than others. OB-GYN, absolutely, almost on a daily basis. Are we dealing with patients who are bleeding, whether it's miscarriage, whether it's abnormal bleeding, and we're trying to find a reason for that. But certainly other applications of ultrasound, it's the same thing. If you're in a hospital and you're working with inpatients, those patients may be catheterized, and you know you're dealing with, you know, filling the bladder and urine. So so yes, you are directly exposed to blood and body fluids. So just remember that. I think when patients or interested parties have asked me about that in the past, you know, they see a vision of, oh, scanning the baby, scanning the belly, and you're just scanning on top of the belly. No, it's a lot more involved in that, especially when it comes to things like, you know, transvaginal or internal ultrasound. So direct contact with blood. Also, we assist with certain procedures. I think one of the leading questions that we included was, are needles involved in ultrasound? Do you have to use needles? And I recently had someone ask me about this on Instagram. She was interested in ultrasound. And I said, you know what? Yes, absolutely. We do have to deal with needles. We as sonographers don't introduce the needle to the patient. That's the physician's job always. But we, in assisting the physician with the examination, you certainly come into contact with the needles. You're preparing the trays, you're opening up, you know, sterile needles and syringes, but, you know, also in things like amniocentesis or breast cyst aspirations or biopsies. we are scanning right alongside the needle, and we're actually guiding, especially with amniocentesis, we actually hold the probe and guide the physician, watch the needle enter into the patient, and we have to guide the physician and the needle into that specific pocket of fluid. So if you have aversion to needles, I say jump right in, and only exposure can get you right over that, right? So let's see, types of jobs. I think that might be the next slide. Yeah. So, here are several of the places where you can go to look for an ultrasound job. So certainly in hospitals, ultrasound is a very important aspect of the radiology department in any hospital. Of course, in the hospital setting, it's where I spent my first 10 years of my career. Certainly, I learned the most about general ultrasound. I practiced a lot of different applications, which is usually the case in a hospital. Abdomen, small parts, OB-GYN, carotids, peripheral vascular, arterial and venous studies. And usually you have call, so rotated weekends and evenings of call, which was never really fun, but part of life in a hospital. Let's see, the other challenging thing about hospital work is, of course, depending on how big your department is, you have to learn to manage emergency room patients with labor and delivery, and inpatients and outpatients. So sometimes it's a bit of a juggle. And I do remember one really interesting night where I'm working like a 3 to 11 shift in the hospital, and both the emergency room and labor and delivery were on 2 different phones, needing me right then. So, what can you do except to say, okay, the 2 of you talk and you guys decide who needs me more immediately. So, those are always interesting times too. So, so great experience in a hospital. Outpatient imaging centers, you may or may not have call there, but obviously they're just outpatients. You don't have the challenge of, inpatients, portable examinations and things like that. Private practice, I was there for 15 years after the hospital, after my hospital stint. The best clinical job I've ever had. It was so great to work. Now, of course, I was specializing in OB-GYN, and I learned so much more about OB-GYN, and usually you do when you specialize, so much more than I did in the entire 10 years of working in the hospital system. Because I was working directly with obstetricians, we were seeing our patients on, more than just one-time visit. We were seeing our patients, sometimes every week. We got to know them well. We developed relationships with them. But more importantly, we were able to get lots of follow-up and feedback from our physicians. So, if we diagnosed a particular case and the physician took his patient to surgery based on what we said, we would get that follow-up. Oh yeah, the thing that you saw in Miss Smith the other day, yeah, it was just what you thought it was. Or no, it wasn't, it was a little different and this was why. So, when you're in a hospital, you see a patient one time, and you don't really get that follow-up. So really great experience in the private OB-GYN setting. So maternal fetal medicine, fertility clinics, those can be outpatient clinics, but they can also be a large department within a hospital setting. Of course, you can teach after you've had a bit of experience and you would rather be on the instruction side. I have found over the years that teaching positions are few and far between, but certainly an option. In some hospitals, I never had the pleasure of being involved in surgical ultrasound applications, but they do exist. And so if you work in a hospital setting, it's more likely that you can be involved in surgical applications of ultrasound, like with the brain, for example. Applications and sales, this is a good one. I was always interested in applications, but applications and sales, it is essentially working for the manufacturer of the ultrasound equipment. So whether it's, say it's GE, or who's a huge manufacturer of ultrasound equipment. Philips is another one. So anyway, you can get a job once you have some experience, once you have some skill developed and you're certified. You can go to work for one of these companies, either in sales, where you are, pitching sales to, say, a hospital. If a hospital is in need of, say, 5 new machines, so you go into the department and you speak to the radiologist there, the other sonographers, the administration, and you evaluate what type of ultrasound they're doing, what their needs are, because just like with, say cars, for example, with any make of car, you've got several different models, right? Same thing for ultrasound. You might have tiny laptops all the way to huge machines that can just do just about anything, with all the bells and whistles that you might find in maternal fetal medicine. So they evaluate your needs, sell you the equipment, and then applications specialists work with the salesman pretty closely. So after the sale, applications comes in and works with the sonographers to teach them how to use the equipment. Not to teach them how to scan, of course, because that's already known. But again, going back to the car reference, when you buy a new car, you might have the salesman sit there and go through with you, okay, here's everything that the car can do. Let's set it all up, and let's show you how to best, use all of the functionality. And so that's what applications does. And then also, there are lots of programs which offer like bachelor's degrees and masters. And so, now I think sonographers have lots more opportunity to be involved in, administration or management. So I think those are great opportunities too for some people. Let's see. See what that next slide. Can you put the next slide up there, and let's see. There we are. Okay, so you don't have to change the slide. I'm just going to go back and finish a couple of thoughts here. So there's, we were talking about private practice, MFM. There are also mobile diagnostic jobs that you can take as well, where you just take a mobile unit and go to, say, nursing homes for echo ultrasounds or vascular scans. Fertility clinics we mentioned, teaching. Yep, okay, we covered it. Okay, so now we'll jump to pay. Seems to be what, of course, no matter what field you go into, pay is important. And I do have to say, ultrasound is all over the board. And it really, really varies depending on where you are, what region of the US you're living in, your level of experience, the number of certifications and what type of certifications, what type of work you do, and where you work. So all of that really plays a part into what you're paid. If you're in a tiny little rural town You might start out at 25,000. That is not a lot of money. Also, you're not, your level of responsibility, hopefully you're supervised, but your level of responsibility, of course, is a little bit less if you're being supervised and you're not very experienced. Sometimes they want someone to come right in who has experience if they don't have to train. But it's not unusual in a rural area to maybe start at 25 or 30,000 a year. So it goes up exponentially depending on, again, all of those factors. Now, I do have to throw out a little disclaimer here. I've never worked in sales. The numbers that I researched said, around 150 to 165 for someone in sales with experience and certification. I don't know how accurate that is, but I would imagine it's probably maybe close within the ballpark. I would imagine if it's off, it may not be off too terribly much. I don't know of anyone who's ever made that kind of money in clinical scanning or in a clinical job, but in sales, or put it this way, applications and sales, remember we said we're kind of tied together. I do know that in applications jobs, for example, let's talk about GE. And I just bring that up because I worked with GE for decades. So if GE is offering a position for applications in women's health, that includes OB-GYN, that includes maternal fetal medicine. So if you are registered in OB-GYN and fetal echo, and you had experience in maternal fetal medicine, and you're willing to travel about 75% of the time, you can make somewhere in the mid 90s or so, and that seems to be about, depending on your territory, about what I've seen for applications jobs in the US. So it doesn't seem unusual to me that sales, you can make quite a bit more because you're selling multi-million dollar units, sometimes to big hospitals. And I would imagine that pay also includes commission. So, but also lots of travel. So there's a little bit of a trade-off there. Yes, it makes good money. Yes, you're always going to be on the road. Let's see. So, okay, we can switch to the next one. Ultrasound schools and programs. So I get this question a lot too. It's hard for me to necessarily recommend any one particular school for ultrasound. So there are so many now and they're so different. It used to be in the very beginning when ultrasound was first a thing, that there was just in hospital training for people who wanted to transition from, say, X-ray to ultrasound. So fast forward today, there's so many programs, and how do you know who is offering you the best foundation going forward in order for you to have a successful career in ultrasound? So the CAA HEP, Commission on Accreditation of Allied Health Education Programs, is a good place to start. You can go to their site, caahep.org. And if you're on a desktop, on the right-hand side, you'll see a box that says, look for an accredited program. On the next page, you'll see a drop-down box on the left that says, enter in your program. So you look for a diagnostic medical sonographer. And then it lets you enter in information like your state and the level of education you're interested in. So that will give you an idea. It will list for you all of the places in your state where you can find an ultrasound program which is certified or accredited through CAA-HEP. Another question I've gotten recently is, am I doomed if I don't go to a CAA-HEP accredited school? No, you're not. I can't speak specifically to, to each and every person's experience, but I do know that a lot of what you get out of a program is what you put into it. And so ask questions, ask questions, ask questions. Get your hands on that probe as much as possible. It's the only way to learn ultrasound. So let's see. Schools vary by length and scope of the program. There are private schools, schools at the college and university level now. Types of training. One of the things you need to look for is what specialties do they teach? Some programs only teach abdomen and OB-GYN. Some teach vascular only, some echo only. Some may teach general ultrasound. And then if you decide, maybe just touch a little bit on adult echo, but it's not nearly enough with an organ as difficult or as complicated as the heart. A lot of sonographers, if interested in echo, will go to an additional 6-month program to study echo after general ultrasound training. Some of the other things that important aspects of your curriculum would be, of course, you have to learn anatomy and physiology, medical terminology. You'll learn about disease processes and how they present. The length of training. If you're right out of high school, it may include, your training may include maths and sciences. If you may be attending a shorter program if you already have some college credits or a 2-year degree. If you already have a bachelor's degree and you're looking into going ultrasound, you still have to learn about all of the fundamental principles of ultrasound, including scanning. So, but you may be able to find a 1 or 2-year program. Financial aid, it's possible and it's out there. Look for grants and loans. I think it's an important part of any education. If you can get that, certainly explore those options. And then your level of training really depends on your end goal. Some people just want to be in and out, so they'll go for a certificate program. If you, like I said, now universities are offering bachelor's degrees and master's degrees. Actually, I searched the website, the caahep.org website, and the only 2 places offering a master's degree in ultrasound is somewhere in Missouri and then Fort Lauderdale, Florida. But for bachelor's, lots more options. So I think that's important if at some point you want to get into administration or management. To have a bachelor's degree is just a little extra layer of protection for you. If you're up for 4 years, I say why not? So let's see. Again, part of the curriculum that's really, really important in any ultrasound program is a balance of class time with clinical time. Clinical rotations should be a really big part of any ultrasound program. You are following other sonographers, you're watching how they interact with patients, how they interact with the physicians, how they present their examinations. Hopefully you'll get some scanning time in there. Scanning labs are really, really important. Like I said before, you have to get your hands on a probe. I know it's been really, really difficult during this period of COVID because, lots of medical practices are, limiting patients' visitors. I know a lot with OB-GYN, they weren't even allowing a spouse to come in and view an ultrasound examination with the spouse, but I understand that necessity. So, I know that students have taken a real hit and being able to do that in the past 1.5 years. So I do also know that there are some some programs that have like ultrasound simulators. I just say whatever you can do, if you can get your hands on a simulator or view, anything that you can view will help you. And then as soon as you can get your hands on a probe again, that's how you get the feel of scanning and finding organs. You can watch someone do it, and then over time you'll learn to recognize what you're seeing on the monitor. And then being handed that probe is an all different world. So then you're handed the probe and they say, reproduce what I just did. And so then you're just kind of like, kind of fishing around in the dark. But with lots of practice, it doesn't take too long before you're able to do the same thing. So persistence is key there, lots and lots of practice. RDMS, get to know these guys because these are, this is your certifying board in the US, the American Registry for Diagnostic Medical Sonography. You will take your examinations through them. You will report to them your continuing medical education credits, and you will pay them your dues every year. They are a wealth of information. If you're interested in examining a little bit more about what types of examinations you can pursue, go to their website. I think they'll provide a lot of information for you. Okay, next slide. So these are I'll just kind of break it down for you a little bit. The ultrasound registry examinations offered by RDMS. So the credentials you can pursue right now in ultrasound are RDMS, RDCS, RVT, RMSKS. So RDMS is what I am, registered medical diagnostic medical sonographer. So you can take your examination in abdomen, breast, fetal echo, neurosonology, OB-GYN, pediatrics, and then SPI is your physics examination. So you must take your physics and then one of the other specialties in order to earn your RDMS credentials. So you have to pass both. You have to pass physics. It's brutal. It is brutal, but you can pass it. We all have. So physics and one of the other specialties. If you pass both, you are registered. If you don't, you have 5 years. I think if you don't pass one of them, you have to wait 3 months before you can retake the examination. But you do have 5 years to take and pass whichever one you failed. And don't feel terrible if you fail it because they are tough. But there are lots of educational materials out there to help you study and pass your examination. Also, if you say you took physics and OB-GYN and you passed them both and you're a registered sonographer, and then a couple of years later, you decide say you're working in a hospital and you're working with a number of applications, and you decide you want to take your abdominal registry exam, you can, and you don't have to take this physics examination again. You don't earn any other credentials. You're still RDMS, but you're registered in 2 areas of that credential. Then RDCS is registered diagnostic cardiac sonographer. So you can take your adult echo examination, your fetal echo examination, either one or both if you want, and your, again, sonography principles, physics and instrumentation examination. Your RVT is a registered vascular technologist, so that's just one examination, and it's physics examination. And then our MSKS is registered musculoskeletal sonographer, and that also has its own physics examination. So The prerequisites for taking the examinations all depend on your level of education and experience, level of work experience. So if you go to ardms.org, you'll be able to explore that and to determine just how long you need to wait before you take your examination. You know, for me, so many years ago, I just went through a certificate program. It was like a year long. So I'd had a couple years of college. Then I went through the ultrasound program. But because I didn't have a bachelor's degree, I needed to have 2 years of work experience. Although they did include my year of ultrasound training in that. So it's a little bit different for everyone, and you'll have to explore that for your own experience there. Let's see. All right, and okay, next slide. So again, I think I mentioned this before, but RDMS dues for a registered sonographer is $85 per year. Just isn't too bad. Every 3 years, you have to submit 30 continuing medical education credits. So you can obtain those through articles or by seminars where you travel. AIUM is a really a great site there and a great institution to be a part of. American Institute of Ultrasound and Medicine includes, they have a huge seminar every year. It's just a wealth of information. So it's a good professional society to be a part of. Also SDMS is another great one. Two great ones for sonographers, lots of information, lots of great opportunities for learning at seminars every year. And another great thing about that is that, you know, it used to be we had to travel to the seminars. Travel is grossly expensive, you know, but now you can pay a little bit less. You don't have to worry about accommodations, and you just watch the webinar on TV and get the same amount, or, you know, on your computer screen and get the same amount of, same number of credits. So that's a real plus. Okay, next one. So I just thought I would share this with you all. Just kind of shows the transformation that we see on ultrasound in the first trimester from week 6 through week 13. The transformation of an embryo to a fetus, and it's pretty amazing. And I still get awed by it when I look at how fast these babies grow. So at 6 weeks gestational age, we've got this tiny little grain of rice. Even at 3.5 millimeters, we can see a heartbeat. That's about the earliest that we can see one. This tiny little sac right here is a yolk sac. Provides nutrients until the placenta is developed. In 1 week, boom, a little bit bigger, 6 whole millimeters bigger, essentially more than doubling in size. You can still see a little yolk sac here. Sometimes they're a little bit collapsed, but if the heartbeat is still strong, then and steady, then that's all good. 8 weeks, we might be able to discern the teeniest, tiniest little wiggle if you look really, really hard for long enough. Again, they grow super fast. Here's a head. Heart would be here. You start to see little arm buds here developing. You would also see leg buds, but they're just a little bit out of angle, so we don't really see that as well. Here is the amnion membrane developing around baby. Now, it really is all the way around, but because it's so tiny and so thin, we only see it best as it's perpendicular to the sound wave. So the sound wave is, this is top, This is mom's belly, right? This is mom's back. So anterior to posterior. And this is why we're able to see the anterior and posterior wall of the amnion a little bit better in that view. So here we are at 9 weeks, 3 days. And I've got a video clip. I have it in my ebook, but it's also on my site too, of this little guy. The dancing they do at 9 weeks is incredible. In 3 short weeks, to go from this tiny little thing, sometimes you have a hard time seeing, to this little guy who's doing a total break dance, is pretty amazing. So here's fetal head, the torso, little arm bud, another arm bud, leg bud, leg bud. Pretty amazing movement. And if you look really closely, you can see a little bit of the amniotic membrane there. Pretty thin, but you can see it there. The next week, 10 weeks, 2 days. This is a side view of baby, head here, bottom at the end. I forgot you can't see my caliper, can you? And then next week, 11 weeks, 12 weeks, you can look at the crown rump. It's what we call the crown rump. From the head to the bottom is a crown rump measurement, and that's how we measure and date a pregnancy early on, determine if interval growth is normal, and to measure and date the embryo or fetus. And so, yeah, that's our first trimester ultrasound growth chart. Pretty cool. And okay, next slide. All right, and so I thought I would include this one just to show you the difference between normal and abnormal in the first trimester. You know, lots of people are interested in OB-GYN, but it is the highest of highs and the lowest of lows. You see lots of sick babies, babies who pass, parents who are hysterical, and naturally so. And that can be quite emotional to deal with. But I think one of the most important aspects of OB-GYN ultrasound that sonographers must remember is empathy. Patients come in to see you, not just in OB-GYN, but in all aspects of ultrasound, in all aspects of allied health, in all aspects of medical medicine and medical care. Your patient may be afraid. Your patient is coming to you because he or she has a problem, or may have a problem, may be sick, maybe they are following up with cancer, maybe they've had a miscarriage previously and they're pregnant again and super anxious about what you'll find. Maybe they've had maybe they have a poor OB history and they're afraid this is miscarriage number 3 or 4 for them. So we have to remember that, you know, I think some sonographers are trained to, you know, not talk to the patient, only look at the monitor, don't interject with the patient. I think that's wrong. We have to develop a relationship with our patients. We have to learn how to speak to them because they're human too. And we have to put ourselves in their shoes. And we have to imagine how we would want to be treated if we were in that situation. Treat your patient the same way. Treat your patient as if that patient was your mother, your sister, or your daughter. Treat your patient the way you would want to be treated. So that said, this is a case of an abnormal baby. So here's our normal scan in the upper left. This is a fetus at 12 weeks, 1 day. And I'm sorry that I cannot show you this. You can't see my arrow, can you? No? No. Okay. So if you look, you can probably make out baby's forehead and face looking up right? So up at the top, you can see the forehead. You move down a little bit, you can see the tip of the nose, the lips, the chin. Okay, if you come straight down from that, do you see the two horizontal lines, two horizontal white lines, a little bit lower, lower, lower on the image, to the right? Look right behind, like right behind the baby's neck. Can you see those, the black line? Perfect, right there. So you see the black line, that's fluid. So the two white lines surrounding that make up a fold of skin. It's called the nuchal translucency. This gives us a great indication of how baby is developing, say, especially with regard to chromosomal development or chromosomally. If what we look for here is a very thin, as you see there, a very thin line of fluid there. So we want that nuchal translucency to be quite thin. So in the baby to the right, on the right side of the screen, you can see in the same space that, yes, you can see how thick that membrane appears, all that thick space between the outer line at the bottom and baby's head. So, considering that with transvaginal imaging, everything is really magnified. So what you're looking at on the left is a nuchal translucency of about 1 millimeter or so. Over here on the right, you're looking at maybe 3 to 4, well, maybe 4 to 5 millimeters. I don't have calipers on that. So what that tells us, and this is only one view, but I could see in all views cross-sectionally, but this was the best view sagittally or longwise, that something wasn't right. Something wasn't developing right in this baby. We don't always know what it is. It could be a chromosomal abnormality. In this case, the patient, the obstetrician would talk to the patient about it and say, look, we see something that doesn't look quite right, but we can't really explain what that is. So we're going to send you to maternal fetal medicine to let them do more testing. At that point, the patient may elect to have first trimester genetic blood testing done, like one is called Harmony, which is just a blood test to determine chromosomal abnormalities. An interesting story additionally to this is that one of my coworkers many years ago diagnosed her own abnormality in her own fetus while scanning herself at 10 weeks pregnant. Her baby looked a lot like the baby on the right. She was referred to maternal fetal medicine. She had CVS sampling done, the chorionic villus sampling, and which came back a normal karyotype. So baby was chromosomally normal. So we knew that there had to be a structural abnormality someplace. And it was just 3 or 4 weeks later, like 13 or 14 weeks, that we were able to, even though we couldn't see it well, we were able to determine that her baby had, instead of 4 chambers in the heart, 1+. So this was a serious heart defect. The heart was not able to pump the fluids in the growing fetus well enough, so that what you see is this accumulation of tissue for a heart that really could not keep up. In utero, he did quite well, but she had to be delivered early in another state, because where we lived, which is one of the pros of ultrasound and one of the things I think is most amazing about this field. I've heard it said before that ultrasound does not contribute a lot to a healthy pregnancy. Maybe it doesn't, but that's not what ultrasound is for. Ultrasound is to diagnose and find a problem so that it can be better managed for the health and and development and growth and development, health and safety for mom and baby. At the end of the day, we want a healthy mom and a healthy baby. Sometimes that means you have to go out of state for delivery. And she did, because fortunately, if ultrasound had not caught this defect, if ultrasound was not a thing, she would have delivered this baby, would have crashed at birth. She would have been in a hospital which had a NICU, but did not have neonatal cardiothoracic surgeons. So this baby, the chances of survival for this baby in any other facility would have been quite limited. So fortunately, it was caught early, and this baby had surgery right after birth, another one at about 3. And he's a feisty little 10 or 11-year-old right now. So it's pretty amazing. 20 years ago, he would not have survived. So pretty cool. Pretty cool how far we've come. So I think that's my last, yeah, that's it. So this is my last slide, which basically says, if we don't get to your question, there's my email address. Write me, ask me anything. I will answer every one of your questions if I haven't already. So I turn it back over to you.
Thank you so much for that presentation.
Mm-hmm.
So for now, we will host a Q&A session for you with like students' questions that they ask in the chat, as well as our questions that we might have. So to start off, this was a question that was asked by a student, and it is, are the RDMS and CAA HEP programs a fellowship/residency?
No. They are, CAA HEP is an accrediting body, which evaluates any program, or put it this way, if your school is interested in being accredited, they would go to CAA HEP and say, we would like to offer an accredited program, and then they would have to go through a rigorous steps for validating their methods for teaching, and so they have to go through this whole approval. I don't know exactly what's involved. I know that certain facilities can be accredited, and they have to go through a similar rigorous campaign to prove that the images and the reporting that they're providing are of a particular standard. And so being a program being accredited through CAA HEP just ensures that you're going to a program that's already passed rigorous approvals for standard of teaching, so that you know you're getting a quality education. Once you have gone through ultrasound training and you have passed your registry, or when you're ready to take your registry examination, you go to ARDMS. ARDMS is who you will take they're the certifying body for sonographers. So when you're ready to take your registry examination, you go to them, you sign up to take your examination with them, and they're the ones who deliver give you information for your testing site, and you get certified through ARDMS. I hope that answers your question.
It does. Thank you so much. So we had another question, and other students in the live session, feel free to drop any of them in the chat or utilize the raise hand function. This was a question dealing with ultrasound. So when doing ultrasound for pregnancy, do you follow a certain scanning pattern on the mother, or do you just scan anywhere on her belly without any pattern per se?
So the protocol for scanning OB is different than scanning any other aspect of any other part of the body, because in any other part of the body, no matter what other type of ultrasound you're performing, the ultrasound is oriented to the patient. So you're either sagittal on the patient, you're transverse on the patient, you're sagittal on the liver, you're transverse on the liver. But it's different in OB. Your orientation is to the fetus. So if the fetus is vertex or head down, then you know are obviously going to be more inferior. You're going to be scanning around the symphysis pubis on mom. So it's all relative to fetal position and not mom. So, usually when we start to learn how to scan OB, one of the easiest things to find is the fetal head. If you're, as long as you're not in the first couple of weeks, the first few weeks of the first trimester, later on, say you're scanning an anatomy screen at 18 to 20 weeks, the first thing you do is pour on the jelly, you scan around, you find the head. It's the only completely oval, rounded, the biggest rounded thing in there. And so from there, you take your measurements of the head, and then, because we all are familiar with our own bodies and form, from there we know how to turn and manipulate the probe to find the spine. And when you find the spine, you trace that down to the lower torso, and then you can find legs and arms and the internal organs once you have made that mental picture of how baby is lying in the uterus.
Thank you for that. That was a great explanation.
Sure.
So we had another question. This is like regarding before you went into your specialty, was there anything that you did not expect when you were going into your specialty?
Before I was going into OB-GYN. I think probably the best answer for that is when you specialize in anything, you become, your skills become really honed in that one specialty. And because I went from scanning, I probably scanned OB-GYN every day, but it wasn't all day, every day. It wasn't every scan that I did. So I was introduced to many more different types of ultrasound examinations that I didn't perform at the hospital level. And because I was scanning so many more OB-GYN patients, I was also seeing a lot more OB-GYN pathology. So I became a lot more familiar with you're seeing it a lot more. You're seeing a lot more of those patients, so you're also seeing a lot more pathology. And so I just got to be a lot more skilled, I guess, at picking out pathology, discovering pathology, noticing pathology that I think I probably would have maybe overlooked in the hospital setting. And we all do. In the process of learning ultrasound, we miss things. We hate to think of that, but this is one thing I didn't cover. I'll mention really quickly, but when you first come out of ultrasound training and you're going into a clinical setting and you're working for the first time, you don't want to work alone. You don't want to work independently because you really don't know a whole lot at that point. You need supervision. You need someone to look over your shoulder. Now, if you're in, 4 years of school and 2 of those years, it was a lot of supervision, you're probably a lot more prepared to work independently when you get your first job. But if not, and you haven't had much clinical training and you haven't had much hands-on experience, supervision is super, super important for the first few months, 3 to 6 months of your first job.
Awesome. So this was a question that just came into the chat. And and they asked, what is the most unique case that you've seen or experienced as a sonographer?
Most unique. Okay, I do remember one in particular. So, you know, over the course of your career, you will remember some of the best cases, some of the worst cases you've ever experienced. Not because you're morose in any way, but because they're fantastic learning experiences. And, you know, we would always joke, you know, only sonographers get excited about seeing pathology. You know, of course, there is a patient attached to the pathology. So, but again, a great learning experience. I was scanning a gynecology patient. She was postmenopausal. She was in her mid 60s, I think, somewhere around there. I believe that she had had an ultrasound somewhere else. I want to say it was maybe at a hospital or an outpatient imaging center. They found a mass in her pelvis. They said it was ovarian, and she decided to seek a second opinion. So she came to the practice and saw a gynecologist and said, "Can you tell me anything else?" So I scanned the patient. And now one thing to know about a postmenopausal patient is that when the ovaries, like many organs, when they're not being used, what do? They atrophy, right? So they get very small. So ovaries in a postmenopausal patient can be very, very difficult to see. But I had discovered over the years that if you scan with a transvaginal probe, and you scan all the way and through the adnexal regions and you get to the iliacs, most of the time, in most every patient, 9 times out of 10, you will find a teeny tiny little 1 centimeter ovary sitting just adjacent, just medial to the iliac vein and artery. So I scan this patient's right adnexa and I see this mass that's in question. And as I'm scanning through, I, see a very large multicystic area. And so while I'm trying to discern what exactly this thing is, I'm scanning slowly and I get to about the area of the iliacs and I see this tiny little thing. And I think to myself, this is her ovary and this is a normal ovary and there's something else going on around it. Well, one of the things that we see a lot in gynecology is hydrosalpinx, which is the fallopian tube that abnormally fills with fluid. It can become quite enlarged and very tortuous, right? So that's what this looked like in the patient. And so my first thought was, she has a normal ovary. This is not an ovarian mass. It looks like a fallopian tube. But one of the other specific characteristics about this area was that within what I call the fallopian tube, looked like these tiny pedunculated areas, and with color flow or with the use of color, which we use a lot on ultrasound to evaluate blood flow, it was highly, highly vascular. So the first thing you think of is, A, this looks abnormal. B, these pedicles that are growing into the mass with multiple septae is not normal, and it lights up with color. That makes you think cancer. So I completed the scan and I took it to my physician, to the obstetrician, the ordering gynecologist. And I said, have you ever seen a fallopian tube cancer? And, a fallopian tube malignancy. And she said, and this is a gynecologist of 30 years at the time. And she said, I've never seen it. but it's not impossible. So she talked with the gynecology oncologist in the area, and she came back to me later and she said, you know, I talked with him and he really thinks it's probably ovarian. And I said, okay, I don't think so. I think that's, you know, and I showed her all of my images and I pointed out what I thought was a normal ovary. And sure enough, they both took that patient to surgery. The next week, I had a note on my desk from her with the patient's name saying fallopian tube carcinoma. So, you know, not a great outcome for the patient, but it feels really good to have been able to correctly diagnose such a complicated problem for a patient. Yeah, so that felt really good.
That's very interesting, especially like
Yeah.
how long it, or how, I'm not sure how long it really took, but the amount of healthcare professionals that you had to like work alongside just to like figure that out is kind of cool.
Yeah, it's really great. And, you know, in a hospital setting, I probably wouldn't have gotten that follow-up. You know, you scan a patient, you know, the radiologist comes in or doesn't come in to see the patient, dictates a report, it goes to the, you know, the ordering physician, and then you never know what happens to the patient after that. And so, yeah, this was just a really great example of being able to follow up on an examination you did and getting some feedback and learning that, you know, what you did, that, you know, A, you were correct, but B, you know, you played a little hand in helping diagnose the patient's problem.
Exactly.
Yeah.
So, this was a question that was sent by Valerie, and she asked, does each specialization have their own specific probe?
No. Well, yes and no. I take that back. Yes and no. You have different types of probes that are good for certain parts of the body, depending on how deep you want to penetrate into the body and what type of imaging you're trying to achieve. So there are some probes that are specific to obstetrics and gynecology. There used to be a long linear probe that seemed to help better for moving around the abdomen, and it was a little deeper in megahertz. It was like a 3 to 5 megahertz, which means that it could penetrate deeper into the abdomen, which is what you want in a big pregnant belly, right? You want to be able to see deeper into the body. But no, some probes can certainly be used interchangeably. But for example, the transvaginal probe, you know, obviously is, you know, really only used for gynecology purposes. But there are other probes that work very superficially that you can use for MSK, for breast, for the thyroid, because you're trying to see just either something just under the skin, or something that's, you know, just fairly superficial to the skin, as opposed to very deep in the belly like a fetus.
Thank you for explaining that. So this is more like a, I guess, like just fun question.
Okay.
But, what is the most, like when you go into your job, what is the most favorite part, or what is your most favorite part about your day-to-day life pertaining to your specialty?
There were a couple of things that I really thought were the best of the best. It was always great to be able to scan your fun couples. You know, it can be difficult working in public health, right? Not everybody likes you. Not everybody wants to come in and be scanned by you or to come in for an exam by you. But, you know, certainly I've had so many couples over the years that were just so fun, and so excited. And so, you know, when it's all great, and baby's healthy and cooperating, those were some highlights. And always fun. Um, One of the other highlights, that I describe in my book is, you know, scanning vaginally, and OB confirmation. So, you know, somebody comes in for the first time, maybe they're 6 or 7 weeks along, maybe it's their first pregnancy and they're super anxious but super excited. Maybe they've miscarried before, and they're really anxious about having the examination done. You know, and so they're with their, you know, partner, spouse, whatever, and you know, they're holding hands in excitement, and you insert the probe and you begin your examination, and the first thing you see is that embryo and that heartbeat. And it's a really special place to be able to point that out. It was always the first thing I did. There it is, there's baby, there's that heartbeat, do you see the flicker? And it's a really special time. You know, they would, you know, cry and celebrate and hug each other. And, you know, and here I am, I'm still, you know, scanning them, doing my examination. But it was a really special moment to be able to share that. You know, also very sad when you can't give good news, but so amazing when you can, and to be able to celebrate with couples, to be able to give them that news, you know, feels pretty amazing. So yeah, that's probably the highlight of my career, I think.
I'm sure that would be like amazing to experience.
Yeah, it was.
But this was a message that was just sent a couple seconds ago. So it looks like they are in high school. They're in high school currently, and they asked, are there any high school programs to, if you're going into like medical field, to get your feet wet and kind of expose yourself to see like which specialty you want to pursue?
I don't know if anything like that is offered at the high school level. But what I would recommend, I do know when I worked in the hospital setting, for any student who was interested in pursuing healthcare, what they would do is volunteer their time. If you can, you know, I know I'm dating myself, but but candy striping, you know, was a thing. You volunteer at a hospital, you know, if you can go to them and say, look, I'm really interested in ultrasound. Can I volunteer to help? You know, some hospitals may allow that. And especially if it's a teaching hospital, where you live, they may have some sort of a program that would allow you to volunteer and have some sort of exposure, to ultrasound, the ultrasound department. I don't know if they would really allow you to see examinations being performed, but if you're able to do that, certainly you would have exposure to the technologists, and you could develop a relationship with them and talk to them about their experience in ultrasound. And I mean, I think that would be a good place to start if you could find it.
Great, thank you. So we have one more question.
Sure.
I'll ask it and then we'll do a wrap-up presentation. And then if you want to provide your contact information at the end, for like students to reach out to you through email or social media, like, feel free to like just drop it in the chat, whatever you want to do.
Okay.
But this was a question that was asked by Valerie, and she asked, have you ever scanned someone that had twins? And how does this, the way of scanning differ in comparison to just scanning for one baby?
Yes, and yes to twins a lot. Lots of twins in OB-GYN. I will say the more rare opportunity was triplets. In my entire 25-year career in clinical, I scanned triplets twice. The same patient in the third trimester. I never wanted to do it again, which is why I didn't go into MFM. They become very difficult to see as they get bigger. Actually, in my book, I follow the journey of a patient of mine who's an OB nurse that who I worked with, who and actually her pregnancy is a set of twins, and so I follow the development of these twins in my book. So yes, I've scanned twins quite a bit. And early on it's quite a bit easier. One of the challenges early on in scanning twins is determining chorionicity. So you want to determine if they're both in the same main chorion sac. Certainly it's healthier if they are each in their own separate sacs. If they are in the same sac, then you want to, at about somewhere around week 10, you can start to see if there's an amnion developing around each baby. So it's very important to determine amnionicity. So you want to be able to see that each baby is growing in its own amnion, in its own bag of amniotic fluid. So if they're not, then that can be a very, very dangerous pregnancy, which may not make it full term. To have two babies in the same amnion and chorion and amniotic sac. So those are some of the things we have to determine early on. A little bit later, we have to determine who's baby A, who's baby B. Baby A will be the first one presenting if a normal labor and delivery, if a vaginal labor and delivery. So baby A would be the lowest toward the cervix. And then we also determine placental number, and if they're sharing a placenta, they are identical. But chorionicity can, or the determining between identical and fraternal can be really, really catchy there. So I don't delve too much into my book, since I am not a geneticist. But certainly as they get, like I said, you do have to determine whether they are sharing a placenta or whether they each have their own. Sharing a placenta, you can run into several issues, like twin-to-twin transfusion syndrome. So it's definitely something to watch. As one baby, you want to see concordant growth. You want to see that each baby is growing at about the same rate. If you start to see a huge discrepancy in that, or a growing discrepancy every time you scan and do a biometry on each of the babies, then that becomes a concern. And then of course, as they get bigger, they start to take up more room. They start to kick each other in the head and so forth. And then in any normally developing pregnancy, amniotic fluid decreases a little bit. So as the babies get bigger and the amniotic fluid decreases, they just become more and more difficult to see. So that with two, it would be extraordinarily challenging for someone new to ultrasound, but sometimes their positions make it pretty challenging for even the most experienced sonographer. When you get three in there, it's like, wow, I'm having a hard time finding which abdomen this head belongs to. And so yeah, size can certainly be a challenge later on. Yeah, and mom gets tired of laying up there for a while, having the examination done too. So yeah, those are the biggest challenges with twins.
Yeah, thank you so much for all your responses and answering all the questions that we had. So right now, I'm just going to do a wrap up. So.
All righty.
Okay, I'm gonna share my screen real quick. Okay. All right, so once again, we want to sincerely thank our presenter for the informative presentation. As someone who's looking forward into going into OBGYN, I definitely learned a lot, and especially with all the pictures, it was really, really informative and very engaging. And I would just like to thank our presenter once again for that wonderful presentation. And I know we are a little bit over time, Dr. Minck, so if you need to go, please feel free to log off. You don't need to stay after because we're just wrapping up a few things. Okay, all right, so now time for the wrap up. So considering this, we would like to encourage everyone to reflect on the session today. So the 3 following questions are: what brought you to our session today? What are the 3 major takeaways that you got? And what do you want to learn more about? So this writing reflection is definitely not required. However, we do encourage you to submit it to our website for publication for recognition of your hard work and to enhance further applications. And if you do want to learn more about prenatal shadowing in the future or get involved in our program, we encourage you to visit our website. You can become an asynchronous volunteer to get certified hours through professional nominations, graphic designs, and social media promotion. We are also accepting team member applications if you want to take on a more active role in PHS, to lead projects and initiatives, to be up here with us. So once again, we are humbly asking that if you're financially able to donate, that you please consider sending a few dollars to us via Venmo or PayPal. It does cost a lot to keep our program up and running and free to you all. So if you are someone who can afford to, or if you know someone else who can, please support those who cannot by donating to our organization so everyone can continue to get the education they deserve. Otherwise, we simply ask you to spread the word about prenatal shadowing to reach as many students as possible. So now for the part that we've been all waiting for. So the earning a digital certificate for the virtual shadowing hour sessions from the session today. So first thing you want to do is go to our website and find our professionals course pages. Next, you can take our quick 10 question-based multiple choice quiz based on the content from the session today. You will have 30 minutes per attempt to earn 70% or higher to get your certificate. We know that sometimes technology can be difficult, and for this reason, we allow 2 attempts to take the assessment. But if you do run into any difficulties, please contact us. To ensure that our website does not crash from a high influx of students, we recommend waiting 30 minutes to an hour after the session to take the quiz, which will be open indefinitely. And then last step, once you have passed, you can click the finish course button at the bottom of the professionals page and download your certificate verifying your virtual shadowing hours. And if you did miss a part of the session or want to go back and view other sessions to earn more certificates with verified virtual shadowing hours, you can go to our YouTube channel and watch our previous recordings. You can also find them via the professional pages on our website and take the post-shadowing assessments for all of these as well. So be sure to follow us on social media or subscribe to our email list for the latest updates on upcoming seasons and events. We are currently booked every weekday through June for virtual shadowing sessions, so I hope to see you all there. And overall, I just want to thank you everyone for joining us today and our professional speaker. So please stick around if you have any questions for myself or the other team members present, and we will be happy to answer them. Now this shadowing session is officially over, and I invite you all to log off. Have a wonderful morning or day.